Varcarolis, Foundations of Psychiatric Mental Health Nursing, 8th edition. Chapter 1, Mental Health and Mental Illness. Key terms and concepts: basic level registered nurse, clinical epidemiology, comorbid condition, cultural competence, Diagnostic and Statistical Manual of Mental Disorders, 5th edition, or DSM-5, diathesis stress model, electronic healthcare, epidemiology, incidence, mental health continuum, mental illness, nursing interventions classification, or NIC, nursing outcomes classification, or NOC, phenomena of concern, prevalence, psychiatric mental health registered nurse, or PMHRN, psychiatric mental health advanced practice registered nurse, or PMHAPRN, psychiatric mental health nursing, recovery, resilience, stigma. If you are a fan of vintage films, you may have witnessed a scene similar to this. A doctor, wearing a lab coat, carrying a clipboard, and displaying an expression of deep concern, enters a hospital waiting room. He approaches an obviously distraught gentleman seated there. The doctor says, "I'm afraid your wife has suffered a nervous breakdown." From that point on in the film, the woman's condition is only vaguely hinted at. The husband dutifully drives through the asylum gates and enters the stately building. Sounds of sobbing or shrieking patients are heard. Patients are rocking on the floor or shuffling down the hall. As he nears his wife's room, the staff regard him with sad expressions and keep a polite distance. He may find his wife lying in her bed motionless, standing by the window and staring vacantly into the distance, or sitting among other non-interacting patients in the hospital's garden. The viewer can only speculate about the true nature of the woman's illness. Mental health and mental illness. We have come a long way in acknowledging and addressing mental illness since the days of nervous breakdowns. In your psychiatric mental health nursing course, you will learn about psychiatric disorders, associated nursing care, and treatments. As a foundation for this learning, we will begin by exploring what it means to be mentally healthy. First, overall health is not possible without good mental health. The WHO describes health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. There is a strong relationship between physical health and mental health. Poor physical health can lead to mental distress and disorders, and poor mental health can lead to physical problems. What does it mean to be mentally healthy? The WHO, again, provides us with a useful definition. Mental health is a state of well-being in which each individual is able to realize his or her own potential, cope with the normal stresses of life, work productively, and make a contribution to the community. Mental health provides people with the capacity for rational thinking, communication skills, learning, emotional growth, resilience, and self-esteem. Some of the attributes of mentally healthy people are shown in Figure 1.1. Society's definition of mental illness evolves over time. It is a definition shaped by the prevailing culture and societal values, and it reflects changes in cultural norms, social expectations, political climates, and even reimbursement criteria by third-party payers. In the past, the term mental illness was applied to behaviors considered strange and different, behaviors that occurred infrequently and deviated from an established norm. Such criteria are inadequate because they suggest that mental health is based on conformity. Applying that definition to nonconformists and independent thinkers, such as Abraham Lincoln, Mahatma Gandhi, and Florence Nightingale, might result in a judgment of mental illness. Although the sacrifices of a Mother Teresa or the dedication of Martin Luther King Jr. are uncommon, virtually none of us would consider these much admired behaviors to be signs of mental illness. Mental illness refers to all psychiatric disorders that have definable diagnoses. These disorders are manifested in significant dysfunctions that may be related to developmental, biological, or psychological disturbances in mental functioning. The ability to think may be impaired, as in Alzheimer's disease. Emotions may be affected, as in major depression. Behavioral alterations, may be apparent as in schizophrenia, or the patient may display some combination of the three alterations. Mental illness is such a common problem that most of us know someone with a disorder. You may even have one yourself. According to the U.S. Department of Health and Human Services in 2014, 1 in 5 American adults experienced a mental health issue. 1 in 10 young people experienced a period of major depression. 1 in 25 Americans lived with a serious mental illness such as schizophrenia, bipolar disorder, or major depression. Suicide was the 10th leading cause of death in the United States. Mental health continuum. You may wonder if there is some middle ground between mental health and mental illness. After all, it is a rare person who does not have doubts as to his or her sanity at one time or another. The answer is that there is definitely a middle ground. In fact, mental health and mental illness can be conceptualized as points along a mental health continuum, figure 1.2. On one end of the continuum is mental health. Well-being describes the general condition of people in this category. Well-being is characterized by adequate to high-level functioning. While individuals at this end of the continuum may experience stress and discomfort resulting from problems of everyday life, they experience no serious impairments in daily functioning. For example, you may spend a day or two in a gray cloud of self-doubt and recrimination over a failed exam, a sleepless night filled with worry about trivial concerns, or months of genuine sadness and mourning after the death of a loved one. During those low times, you are fully or vaguely aware that you are not functioning well. However, time, exercise, a balanced diet, rest, interaction with others, and mental reframing may alleviate these problems or concerns. At the opposite end of the continuum is mental illness. Individuals may have emotional problems or concerns and experience mild to moderate discomfort and distress. Mild impairment in functioning, such as insomnia, lack of concentration, or loss of appetite, may be felt. If the distress increases or persists, individuals might seek professional help. Problems in this category tend to be temporary, but individuals with mild depression, generalized anxiety disorder, and attention deficit disorder may fit into this group. The most severely affected individuals fall into the mental illness portion of the continuum. At this point, individuals experience altered thinking, mood, and behavior. It may include relatively common disorders such as depression and anxiety, as well as major disorders such as schizophrenia. The distinguishing factor in mental illness is typically chronic or long-lasting impairments that range from moderate to disabling. All of us fall somewhere on the mental health, mental illness continuum and shift gradually or suddenly. Many people will never move into the mental illness stage. On the other hand, many people who do reach a more severe level of impairment can experience recovery that ranges from a glimmer of hope to leading a satisfying life. People who have experienced mental illness can testify to the existence of changes in functioning. The following comments of a 40-year-old woman illustrate the continuum between illness and health as her condition ranged from deep depression to mania to well-being, recovery. Depression. It was horror and hell. I was at the bottom of the deepest and darkest pit there ever was. I was worthless and unforgivable. I was as good as, no, worse than, dead. Mania. I was incredibly alive. I can sense and feel everything. I was sure I could do anything, accomplish any task, and create whatever I wanted if only other people wouldn't get in my way. Well-being, recovery. I am much calmer. I realize now that when I was manic, it was a pressure cooker feeling. When I am happy now, or loving, it was more peaceful and real. I have to admit that I sometimes miss the intensity, the sense of power and creativity of those manic times. I never miss anything about the depressed times, but of course, the power and the creativity never bore fruit. Now I do get things done, some of the time, like most people, and people treat me much better now. I guess I must seem more real to them. I certainly seem more real to me. Risk and protective factors. Many factors can affect the severity and progression of a mental illness, as well as the mental health of a person who does not have a mental illness. Individual characteristics and attributes influence mental health and well-being. Socioeconomic circumstances and the environment also influence mental health. Individual attributes and behaviors. Individual attributes refer to characteristics that are both inborn and learned that make us who we are. We all have unique ways of managing thoughts and feelings and navigating the everyday pressures of life. The ability to respond to social cues and participate in social activities influences our view of ourselves and how others view us. Biological and genetic factors can also influence mental health. Prenatal exposure to alcohol and oxygen deprivation at birth are two examples of biological factors. Genetic factors are huge predictors of mental health and are implicated in nearly every psychiatric disorder. What makes some people adapt to tragedy, loss, trauma, and severe stress better than others? The answer may be the individual attribute of resilience. Resilience is the ability and capacity for people to secure the resources they need to support their well-being. It is a quality found in some children of poverty and abuse who seek out trusted adults. These adults provide them with the psychological and physical resources that allow them to excel. Being resilient does not mean being unaffected by stressors. People who are resilient are effective at regulating their emotions and not falling victim to negative, self-defeating thoughts. You can get an idea of how good you are at regulating your emotions by taking the Resilience Factor Test in Box 1.1. Social and economic circumstances. Your immediate social surroundings impact personal attributes. The earliest social groups, the family, has tremendous effects on developing and vulnerable humans. The family sets the stage in promoting confidence and coping skills or for instilling anxiety and feelings of inadequacy. The social environment extends to schools and peer groups. Again, this environment has the ability to affect mental health positively and negatively. For example, socioeconomic status dictates the sort of resources available to support mental health and reduce concerns over basic needs such as food, clothing, and shelter. Educational advancement is a tremendous supporter of mental health by providing opportunities for a satisfying career, security, and economic benefits. Environmental factors. The overall environment that affects mental health relates to the political climate and cultural considerations. Access and lack of access to basic needs and commodities such as healthcare, water, safety services, and a strong highway system have a profound effect on community mental health. Social and economic policies, which are formed at the global, national, state, and local government levels, also impact mental health. For example, in the United States, laws have been gradually shifting towards better reimbursement for mental health services. This shift makes it easier to access and improve mental health care. Predominant cultural beliefs, attitudes, and practices influence mental health. There is no standard measure for mental health, partly because it is culturally defined. One approach to differentiating mental health from mental illness is to consider what a particular culture regards as acceptable or unacceptable. In this view, those with mental illness are those who violate social norms and thus threaten or make anxious those observing them. For example, traditional Japanese culture may consider suicide to be an act of honor, and Middle Eastern suicide bombers are considered holy warriors or martyrs. Contrast these viewpoints with Western culture, where people who attempt or complete suicides are nearly always considered mentally ill. Throughout history, people have interpreted health or sickness according to their own current views. A striking example of how cultural change influences the interpretation of mental illness is an old definition of hysteria. According to Webster's Dictionary, Porter, 1913, hysteria was a nervous affection in women in which the emotional and reflex excitability is exaggerated and the willpower correspondingly diminished, so that the patient loses control over the emotions. becomes the victim of imaginary sensations, and often falls into paroxysm or fits. Treatment for this condition, thought to be the result of sexual deprivation, often involved sexual activity. Thankfully, this diagnosis fell into disuse as women's rights improved, the family atmosphere became less restrictive, and societal tolerance of sexual practices increased. Cultures differ not only in their views regarding mental illness, but also the types of behavior categorized as mental illness. Culture-bound syndromes seem to occur in specific sociocultural contexts, and people in those cultures easily recognize them. For example, one syndrome recognized in parts of Southeast Asia is running amok, in which a person, usually a male, runs around engaging in almost indiscriminate violent behavior. In the United States, anorexia nervosa is recognized as a disorder characterized by voluntary starvation. The disorder is well known in Europe, North America, and Australia, but unheard of in many other parts of the world. Perceptions of mental health and mental illness. Mental illness versus physical illness. People often make a distinction between mental illness and physical illnesses. This is a peculiar distinction. Mental refers to the brain, the most complex part of the body, responsible for the higher thought processes that set us apart from all other creatures. Surely the workings of the brain, the synaptic connections, the areas of functioning, the spinal innervations, and connections are physical. One problem with this distinction is that it implies that psychiatric disorders are, quote, all in the head. Most damaging is the belief that these disorders are under personal control and indistinguishable from a choice to engage in bad behavior. These beliefs support the stigma to which people with mental illness are often subjected. Stigma, the belief that the overall person is flawed, is characterized by social shunning, disgrace, and shame. Perhaps the difference between mental and physical illness lies in the tradition of explaining the unexplainable through superstition. Consider that the frightening convulsions of epilepsy were once explained as demon possession or a curse. Unfortunate individuals with epilepsy were subjected to horrible treatment including shunning, imprisonment, and exorcisms. Today, people recognize that seizures are part of a disorder and not under personal control. How do we know? Because we can see epilepsy on brain scans as areas of overactivity and excitability. There are no specific biological tests to diagnose most psychiatric disorders, no cranium culture for depression, and no MRI for OCD. However, researchers are convinced that the root of most mental disorders lies in intercellular abnormalities. We can now see clear signs of altered brain function in several mental disorders, including schizophrenia, OCD, stress disorders, and depression. Nature versus nurture. For centuries, people believed that extremely unusual behaviors resulted from supernatural, usually evil, forces. In the late 1800s, the mental health pendulum swung briefly to a biological focus with the germ theory of diseases. Germ theory explained mental illness in the same way other illnesses were being described. That is, a specific agent in the environment caused them. This theory was abandoned rather quickly because clinicians and researchers could not identify causative factors for mental illnesses. There was no mania germ that could be viewed under a microscope and subsequently treated. Although biological treatments for mental illness continued to be explored, psychological theories dominated and focused on the science of the mind and behavior. These theories explained the origin of mental illness as faulty psychological processes that could be corrected by increasing personal insight and understanding. For example, a patient experiencing depression and apathy could be assisted to explore feelings from childhood when overly protective parents strictly discouraged attempts at independence. The psychological focus was challenged in 1952 when chlorpromazine, or thorazine, was found to have a calming effect on agitated, out-of-control patients. Imagine what this discovery must have been like for clinicians. Out of desperation, they had resorted to every biological treatment imaginable, including wet wraps, insulin shock therapy, and psychosurgery, in which holes were drilled in the head of a patient and probes inserted into the brain, as attempts to change behavior. The scientific community began to believe that if psychiatric problems responded to medications that alter neurochemistry, then the disruption of intercellular components must already be present. A diathesis stress model, in which diathesis represents biological predisposition and stress represents environmental stress or trauma, is the most accepted explanation for mental illness. This nature plus nurture argument asserts that most psychiatric disorders result from a combination of genetic vulnerability and negative environmental stressors. One person may develop major depression largely as a result of inherited and biological vulnerability that alters brain chemistry. Another person with little vulnerability may develop depression as a result of a stressful environment that causes changes in brain chemistry. Social influences on mental health care. Consumer movement and mental health recovery. Over 100 years ago, tremendous energy was directed towards improving equality in the United States. Black men were given the right to vote in 1870, as were women, finally, in 1920. Treating people fairly and challenging labels became a focus of the American culture. With regard to treatment of people with mental illness, decades of institutionalization had created significant political and social concerns. Groups of people with mental illnesses, frequently called mental health consumers, began to advocate for their rights and fought against discrimination and forced treatment. In 1979, people with mental illnesses and their families formed a nationwide advocacy group, the National Alliance on Mental Illness, or NAMI. In the 1980s, individuals in the consumer movement organized by NAMI began to resist the traditional arrangement of mental health care providers dictating treatment without the input of the patient. This paternalistic relationship was demoralizing, and it also implied that patients were not competent to make their own decisions. Consumers demanded increased involvement in decisions concerning their treatment. The consumer movement also promoted the concept of recovery, a new and an old idea. On one hand, it represents a concept that has been around a long time, that some people, even those with the most serious illnesses, such as schizophrenia, recover. One recovery was depicted in the movie A Beautiful Mind. In this film, a brilliant mathematician, John Nash, seems to have emerged from a continuous cycle of devastating psychotic relapses to a state of stabilization and recovery. A newer conceptualization of recovery evolved into a consumer-focused process. According to the Substance Abuse and Mental Health Services Administration, SAMHSA, recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. The focus is on the consumer and what he or she can do. A real-life example of recovery follows. I'm going to skip this vignette here. Decade of the Brain. In 1990, President George H.W. Bush designated the last decade of the 1900s as the decade of the brain. The overriding goal of this designation was to make legislators and the public aware of the advances that had been made in neuroscience and brain research. The U.S. initiative stimulated a worldwide growth of scientific research. Advances and progress made during the decade of the brain include understanding the genetic basis of embryonic and fetal neural development, mapping genes involved in neurological illnesses, including mutations associated with Parkinson's disease, Alzheimer's disease, and epilepsy, discovering that the brain uses a relatively small number of neurotransmitters but has a vast assortment of neurotransmitter receptors, uncovering the role of cytokines, proteins involved in the immune response, in such disorders as depression, refining neuroimaging techniques, bringing together computer modeling and laboratory research, which resulted in the new discipline of computational neuroscience. Surgeon General's report on mental health. The first Surgeon General's report on the topic of mental health was published in 1999. This landmark document was based on an extensive review of the scientific literature in consultation with mental health providers and consumers. The two most important messages from this report were that 1, mental health is fundamental to overall health, and 2, there are effective treatments. The report is reader-friendly and a good introduction to mental health and illness. You can review this report at www.blah. Human Genome Project. The Human Genome Project was a 13-year project that lasted from 1990 to 2003 and was completed on the 50th anniversary of the discovery of the DNA double helix. The project has strengthened biological and genetic explanations for psychiatric conditions. The goals of the project were to do the following: identify the approximately 20,000 to 25,000 genes in human DNA, determine the sequence of the 3 billion chemical base pairs that make up human DNA, store this information in databases, improve tools for data analysis, address the ethical, legal, and social issues that may arise from the project. Researchers are continuing to make progress in understanding genetic underpinnings of disease and disorders. You will be learning about these advances in the clinical chapters that follow. President's New Freedom Commission on Mental Health. The President's New Freedom Commission on Mental Health, chaired by Michael Hogan, released its recommendations for mental health care in America in 2003. This was the first commission since First Lady Rosalind Carter's, wife of President Jimmy Carter, in 1978. The report stated that the system of delivering mental health care in America was in a shambles. It called for a streamlined system with less fragmentation in the delivery of care. The Commission advocated for early diagnosis and treatment, adoption of principles of recovery, and increased assistance in helping people find housing and work. Box 1.2 describes the goals necessary for such a transformation of mental health care in the United States. Institute of Medicine. The Improving the Quality of Healthcare for Mental and Substance Use Conditions Quality Chasm series was released in 2005 by the Health and Medicine Division of the National Academies of Medicine, formerly the Institute of Medicine. It highlighted effective treatments for mental illness and addressed the huge gap between the best care and the worst. It focused on such issues as the problem of forced treatment, a system that treats mental health issues separately from physical health problems, and lack of quality control. The report encouraged healthcare workers to focus on safe, effective, patient-centered, timely, efficient, and equitable care. Another important and related publication issued by the Institute of Medicine in 2011 is The Future of Nursing, Focus on Education. This report contends that the old way of training nurses is not adequate for the 21st century's complex requirements. It calls for highly educated nurses who are prepared to care for an aging and diverse population with an increasing incidence of chronic disease. They recommend that nurses be trained in leadership, health policy, system improvement, research, and teamwork. Yeah. Quality and safety education for nurses. Recommendations for both documents were addressed by a group called Quality and Safety Education for Nurses, QSEN, and were funded by the Robert Wood Johnson Foundation. They have developed a structure to support the education of future nurses who possess the knowledge, skills, and attitudes to continuously improve the safety and quality of healthcare. Consider this tragic story. Betsy Lehman was a health reporter for the Boston Globe who was married to a cancer researcher. When she herself was diagnosed with cancer, she was prescribed an incorrect, extremely high dose of an anti-cancer drug. Miss Lehman sensed something was wrong and appealed to the healthcare providers who did not respond to her concerns. The day before she died, she begged others to help because the professionals were not listening. How could her death have been prevented? Consider the key areas of care promoted by QSEN and how they could have prevented Miss Lehman's death. Number 1, patient-centered care. Care should be given in an atmosphere of respect and responsiveness, and the patient's values, preferences, and needs should guide care. 2, teamwork and collaboration. Nurses and interprofessional teams need to maintain open communication, respect, and shared decision-making. Evidence-based practice. Optimal healthcare is the result of integrating the best current evidence while considering the patient family values and preferences. 4, quality improvement. Nurses should be involved in monitoring the outcomes of the care that they give. They should also be care designers and test changes that will result in quality improvement. 5, safety. The care provided should not add further injury, e.g., nosocomial infections. Harm to patients and providers are minimized through both system effectiveness and individual performance. 6, informatics. Information and technology are used to communicate, manage knowledge, mitigate error, and support decision-making. Brain research through Advancing Innovative Neurotechnologies, BRAIN Initiative. In 2013, President Barack Obama announced that $300 million in public and private funding would be devoted to the brain research, the thing I just said. This money would be used to develop innovative techniques and technologies to unravel the mystery of how the brain functions. The goal is to uncover new ways to prevent, treat, and cure psychiatric disorders, epilepsy, and traumatic brain injury. According to the National Institutes of Health, more than $70 million is going to over 170 researchers working at 60 different institutions. These researchers are examining such topics as developing computer programs that may help researchers detect and diagnose autism and Alzheimer's disease from brain scans, building a cap that uses ultrasound waves to precisely stimulate brain cells, creating a neural dust system made of tiny electric sensors for wirelessly recording brain activity, improving current rehabilitation technologies for helping the lives of stroke patients, and studying how the brain reads and speaks. Research Domain Criteria, RDOC, Initiative. In other specialty areas, symptom-based classification has been replaced by more scientific understanding of the problem. For example, physicians do not make a cardiac diagnosis depending on the type of chest pain a person is having, but rather on diagnosing the specific problems such as myocarditis. Psychiatry continues to rely heavily on symptoms in the absence of objective and measurable data. In 2013, the National Institute of Mental Health, NIMH, announced that it would no longer fund DSM diagnosis-based studies. Instead, it would put all of its time, effort, and money into something called the Research Domain Criteria, or RDoC, initiative. This promising initiative challenges researchers to seek causes for mental disorders at the molecular level. NIMH hopes to transform the current diagnostic procedure by using genetics, imaging, and fresh information to create a new classification system. Legislation and mental health funding. Mental health parity. Imagine insurance companies singling out a group of disorders such as digestive diseases for reduced reimbursement. Imagine people with colon cancer being assigned higher copays than other cancers. Imagine limiting the number of treatments for which patients could be reimbursed for Crohn's disease over a lifetime. People would be outraged by such discrimination. Yet, this is exactly what has happened with psychiatric disorders. Too often, insurance companies did not cover mental health care at all, identified yearly or lifetime limits on mental health coverage, limited hospital days or outpatient treatment sessions, and assigned higher co-payments or deductibles. In response to this problem, advocates fought for parity. This term means equivalence or equal treatment. The Mental Health Parity Act was passed in 1996. This legislation required insurers that provide mental health coverage to offer annual and lifetime benefits at the same level provided for medical surgical coverage. Unfortunately, by the year 2000, the Government Accounting Office found that although 86% of health plans complied with the 1996 law, 87% of those plans actually imposed new limits on mental health coverage. The Wellstone Dominici Parity Act was enacted in 2008 for group health plans with more than 50 employees. The law required that any plan providing mental health coverage must do so in a manner that is functionally equivalent or on par with coverage of other health conditions. This parity pertains to deductibles, co-payments, co-insurance, and out-of-pocket expenses, as well as treatment limitations, e.g. frequency of treatment and number/frequency of visits. Patient Protection and Affordable Care Act of 2010. Parity laws were a good first step in providing more equitable coverage for mental health care. However, parity laws do not require health plans to cover psychiatric care. Furthermore, the parity laws only apply to large insurers. The Patient Protection and Affordable Care of 2010, ACA, improves coverage for most Americans who are uninsured through a combination of expanded Medicaid eligibility for the very poor, creation of health insurance exchanges in the states to serve as a broker to help uninsured consumers choose among various plans, and the so-called insurance mandate, a requirement that people without coverage obtain it. The ACA improves mental health care coverage in several ways. Eliminates medical underwriting in the individual and small group markets, so medical history no longer results in enrollment denials for pre-existing conditions or higher premiums. Requires all individuals and small group health plans to cover 10 essential health benefits with no annual or lifetime dollar limits. Mental health and addiction treatment are among the essential benefits. Makes health insurance with mental health benefits available for many individuals who previously had been uninsured. Significant numbers of these, mostly low-income persons, had untreated mental health problems. Provides for prescription coverage for all new individual and small group health plans, including medications to treat behavioral health problems. Requires all non-grandfathered health plans, including large group plans, to cover a range of preventative care at no cost to the patient. Allows young adults to remain on their parents' health plans until age 26. This is important to mental health since most psychiatric disorders emerge in adolescence or early 20s. Although the ACA has dramatically improved mental health care coverage, there are still problems. Problems include finding a mental health professional for care within certain plans and limited coverage for some brand-name drugs, especially antipsychotics. Also, health insurance companies may be more than twice as likely to deny authorization for mental health care compared with authorization for general medical care. Hopefully, these deficiencies will be addressed as the ACA continues to be evaluated and evolves. Epidemiology of mental disorders. Epidemiology, as it applies to psychiatric mental health, is a quantitative study of the distribution of mental disorders in human populations. Understanding this distribution helps identify high-risk groups and risk factors associated with illness onset, duration, and recurrence. According to SAMHSA, nearly 44 million adults in the United States experienced a diagnosable mental illness in 2013. In fact, neuropsychiatric disorders are the leading category of disease, with twice the disability as the next category, cardiovascular diseases. More than a third of this disability is caused by depression. Individuals may have more than one mental disorder or another medical disorder. The simultaneous existence of two or more disorders is known as comorbid condition. For example, schizophrenia is frequently comorbid with diabetes. Two different but related words used in epidemiology are incidence and prevalence. Incidence conveys information about the risk of contracting a disease. It refers to the number of new cases of mental disorders in a healthy population within a given period of time, usually annually. An example of incidence is the number of Atlanta adolescents who were diagnosed with major depression between 2000 and 2001. Prevalence describes the total number of cases, new and existing, in a given population during a specific period of time, regardless of when they became ill. An example of prevalence is the number of adolescents who screened positive for major depression in New York City schools between 2000 and 2010. A disease with a short duration, such as the common cold, tends to have a high incidence, many new cases in a given year, and a low prevalence, not many people suffering from a cold at any given time. Conversely, a chronic disease, such as diabetes, will have a low incidence because the person will be dropped from the list of new cases after the first year, or whatever time increment is being used. Lifetime risk data, or the risk that one will develop a disease in the course of a lifetime, will be higher than both incidence and prevalence. According to Kessler, Berglund, and colleagues, 46.4% of all Americans will meet the criteria for a psychiatric disorder in their lifetimes. Table 1.1 shows the prevalence of some psychiatric disorders in the United States. Originally, epidemiology meant the study of epidemics. Clinical epidemiology is a broad field that examines health and illness at the population level. Studies use traditional epidemiological methods and are conducted in groups usually defined by the illness or symptoms or by the diagnostic procedures or treatments given for the illness or symptoms. Clinical epidemiology includes the following: studies of the natural history, what happens if there is no treatment and the problem is left to run its course, of an illness, studies of diagnostic screening tests, observational and experimental studies of interventions used to treat people with the illness or symptoms. Analysis of epidemiological studies can reveal the frequency with which psychological symptoms appear together with physical illness. For example, epidemiological studies demonstrate that depression is a significant risk factor for death in people with cardiovascular disease and premature death in people with breast cancer. Classification of mental disorders. Nursing care, as opposed to medical care, is care based on responses to illness. Registered nurses do not diagnose, prescribe, and treat major depression. They treat the problem associated with depression, such as insomnia or hopelessness. Nurses provide effective care using the nursing process as a guide to holistic care. Nurses, physicians, and other healthcare providers are part of an interprofessional team. When the team is well coordinated, it can provide optimal care for the biological, psychological, social, and spiritual needs of patients. To carry out their diverse professional responsibilities, educators, clinicians, and researchers need clear and accurate guidelines for identifying and categorizing mental illness. For clinicians in particular, such guidelines help in planning and evaluating their patients' treatment. At present, there are two major classification systems used in the United States: the Diagnostic and Statistical Manual, 5th edition, DSM-5, and the International Classification of Disease, 10th revision, Clinical Modification, ICD-10-CM. Both are important in terms of planning for patient care and determining reimbursement for services. However, the DSM-5 is the dominant method of categorizing and diagnosing mental illnesses in the United States and is the framework for clinical disorders in this textbook. The DSM-5. The DSM is a publication of the APA. First published in 1952, the latest 2013 edition describes criteria for 157 disorders. The development of the DSM-5 was influenced by clinical field trials conducted by psychiatrists, psychiatric mental health advanced practice registered nurses, psychologists, licensed clinical social workers, licensed counselors, and licensed marriage and family therapists. The DSM identifies disorders based on specific criteria. It is used in inpatient, outpatient, partial hospitalization, consultation liaison, clinics, private practice, primary care, and community settings. The DSM also serves as a tool for collecting epidemiological statistics about the diagnosis of psychiatric disorders. The following is a list of disorder categories in the DSM-5. You may notice that the order of the list is similar to the way the chapters are organized in this textbook. 1. Neurodevelopmental disorders. 2. Schizophrenia spectrum disorders. 3. Bipolar and related disorders. 4. Depressive disorders. 5. Anxiety disorders. 6. OCD. 7. Trauma and stressor related disorders. 8. Dissociative disorders. 9. Somatic symptom disorders. 10. Feeding and eating disorders. 11. Elimination disorders. 12. Sleep-wake disorders. 13. Sexual dysfunctions. 14. Gender dysphoria. 15. Disruptive impulse control and conduct disorders. 16. Substance-related and addictive disorders. 17. Neurocognitive disorders. 18. Personality disorders. 19. Paraphilic disorders. And 20. Other disorders. A common misconception is that a classification of mental disorders classifies people, when the DSM actually classifies disorders. For this reason, the DSM and this textbook avoid the use of such labels as a schizophrenic or an alcoholic. Viewing the person as a person and not as an illness requires more accurate terms such as an individual with schizophrenia or my patient has major depression. The ICD-10-CM. In an increasingly global society, it is important to view the United States diagnosis and treatment of mental illness as a part of a bigger picture. The International Standard of Disease Classification is the ICD-10. The United States has adapted this resource with a clinical modification, hence its title of ICD-10-CM. Psychiatric mental health nursing. In most clinical settings, nurses work with people going through a variety of crises. These crises may be based on physical, psychological, mental, and spiritual distress. Most of you have already come across people going through difficult times in their lives. While you may have handled these situations well, there may have been times when you wish you had additional skills and knowledge. The psychiatric nursing rotation will greatly increase your insight into the experiences of others with mental health alterations. Exploring mental health and mental illness may even help you increase insight into yourself. You will learn essential information about psychiatric disorders and hopefully have the opportunity to develop new skills for dealing with a variety of behaviors associated with them. The rest of this chapter is devoted to psychiatric nursing, what psychiatric nurses do, their scope of practice, and the challenges and evolving roles for the future healthcare environment. What is psychiatric mental health nursing? Psychiatric mental health nursing is the nursing specialty that is dedicated to promoting mental health through the assessment, diagnosis, and treatment of behavioral problems, mental disorders, and comorbid conditions across the lifespan. Psychiatric mental health nurses work with people throughout their lifespan, children, adolescents, adults, and the elderly. Psychiatric mental health nurses assist people who are in crises or who are experiencing life problems, as well as those with long-term mental illness. These nurses work with patients with dual diagnosis, e.g. mental disorder and a comorbid substance disorder, homeless persons and families, forensic patients, i.e. people in jail, and individuals who have survived abusive situations. Psychiatric mental health nurses work with individuals, couples, families, and groups in every nursing setting. They work with patients in hospitals, in their homes, in halfway houses, in shelters, in clinics and storefronts, on the street, virtually everywhere. The Psychiatric Mental Health Nursing Scope and Standards of Practice defines the specific activities of the psychiatric mental health nurse. This publication, jointly written in 2014 by the American Nurses Association and the American Psychiatric Nurses Association and the International Society of Psychiatric Mental Health Nurses, defines the focus of psychiatric mental health nursing as promoting mental health through the assessment, diagnosis, and treatment of human responses to mental health problems and psychiatric disorders. The psychiatric mental health nurse uses the same nursing process you have already learned to assess and diagnose patients' illnesses, identify outcomes, and plan, implement, and evaluate nursing care. Box 1.3 describes phenomena of concern, human experiences and responses for psychiatric mental health nurses. Box 1.3, phenomena of concern for psychiatric mental health nurses. Promotion of optimal mental and physical health and well-being. Prevention of mental and behavioral distress and illness. Promotion of social inclusion of mentally and behaviorally fragile individuals. Co-occurring mental health and substance use disorders. Co-occurring mental health and physical disorders. Alterations in thinking, perceiving, communicating, and functioning related to psychological and physiological distress. Psychological and physiological distress resulting from physical, interpersonal, and/or environment trauma or neglect. Psychogenesis and individual vulnerability. Complex clinical presentations confounded by poverty and poor, inconsistent, or toxic environmental factors. Alterations in self-concept relating to loss of physical organs and/or limbs, psychic trauma, developmental conflicts, or injury. Individual, family, or group isolation and difficulty with interpersonal relations. Self-harm and self-destructive behaviors including mutilation and suicide. Violent behavior including physical abuse, sexual abuse, and bullying, and low health literacy rates contributing to treatment non-adherence. Classification of nursing diagnosis, outcomes, and interventions. To provide the most appropriate and scientifically sound care, the psychiatric mental health nurse uses standardized classification systems developed by professional nursing groups. The book Nursing Diagnoses, Definitions and Classification 2015 and 2017 of the North American Nursing Diagnosis Association International, or NANDI, provides standardized diagnoses, many of which are related to psychosocial or psychiatric nursing care. These diagnoses provide a common language to aid in the selection of nursing interventions and ultimately lead to outcome achievement. DSM-5 and NANDI approved nursing diagnoses. Psychiatric mental health nursing includes the diagnosis of treatment of human responses to actual or potential mental health problems. A nursing diagnosis is a clinical judgment concerning a human response to health conditions / life process or vulnerability for that response by an individual, family, group, or community. While the DSM-5 is used to diagnose a psychiatric disorder, a well-defined nursing diagnosis provides the framework for identifying appropriate nursing interventions for dealing with the patient's reaction to the disorder. Nursing Outcomes Classification. The NOC is a comprehensive source for standardized outcomes and definitions of these outcomes. A 5-point Likert scale is used with all outcomes and indicators. A rating of 5 is always the best possible score, and a rating of 1 is always the worst possible scale. This textbook has a lot of errors. Words used in the scales include 1 equals extremely compromised to 5 equals not compromised, and 1 never demonstrated to 5 equals consistently demonstrated. The 490 outcomes are listed in alphabetical order. Outcomes are organized into 7 domains: functional health, physiological health, psychosocial health, health knowledge and behavior, perceived health, family health, and community health. The psychosocial health domain includes 4 classes: psychological well-being, psychosocial adaptation, self-control, and social interaction. Nursing Interventions Classification, or NIC. The NIC is another book used to standardize, define, and measure nursing care. The NIC defines a nursing intervention as any treatment based upon clinical judgment and knowledge that a nurse performs to enhance patient-client outcomes, including direct and indirect care through a series of nursing activities. There are 7 domains: basic, physiological, complex physiological, behavioral, safety, family, health system, and community. 2 domains relate specifically to psychiatric nursing: behavioral, including communication, coping, and education, and safety, covering crisis and risk management. Levels of psychiatric mental health clinical nursing practice. Psychiatric mental health nurses are registered nurses educated in nursing and licensed to practice in their individual states. Psychiatric nurses are qualified to practice at two levels, basic and advanced, depending on educational preparation. Table 1.2 describes basic and advanced psychiatric nursing interventions. Basic level. Basic level registered nurses are professionals who have completed a nursing program, passed the state license exam, and are qualified to work in most any general or specialty area. The Psychiatric Mental Health Registered Nurse, PMHRN, is a nursing graduate who possesses a diploma, an associate degree, or a baccalaureate degree, and chooses to work in the specialty of psychiatric mental health nursing. At the basic level, nurses work in various supervised settings and perform multiple roles such as staff nurse, case manager, home care nurse, and so on. After 2 years of full-time work as a registered nurse, 2,000 clinical hours in a psychiatric setting, and 30 hours of continuing education in psychiatric nursing, a baccalaureate-prepared nurse may take a certification exam administered by the American Nurses Credentialing Center to demonstrate clinical competence in psychiatric mental health nursing. After passing the exam, a board-certified credential is added to the RN title, resulting in RNBC. Certification gives nurses a sense of mastery and accomplishment, identifies them as competent clinicians, and satisfies the requirement for reimbursement by employers in some states. Advanced practice. One of the first advanced practice nursing roles in the United States was a psychiatric clinical nurse specialist in the 1950s. These expert nurses were originally trained to provide individual therapy and group therapy in state psychiatric hospitals and to provide training for other staff. Eventually, they, along with psychiatric nurse practitioners who were introduced in the mid-1960s, gained diagnostic privileges, prescriptive authority, and the ability to provide psychotherapy. Currently, the Psychiatric Mental Health Advanced Practice Registered Nurse, PMH-APRN, is a licensed registered nurse with a Master of Science in Nursing, or Doctor of Nursing Practice, in psychiatric nursing. This DNP is not to be confused with a doctoral degree in nursing, PhD, which is a research degree, whereas the DNP is a practice doctorate. The PMH-APRN may function autonomously depending on the state and is eligible for specialty privileges. Some advanced practice nurses continue their education to the PhD level. Unlike other specialty areas, there is no significant difference between a psychiatric nurse practitioner and a clinical nurse specialist, as long as the CNS has achieved prescriptive authority. Certification is required and is obtained through the American Nurses Credentialing Center. Only one examination, the Psychiatric Mental Health Nurse Practitioner Board Certified, is currently available. 3 other examinations have been discontinued: the Adult Psychiatric Mental Health Nurse Practitioner Board Certified, the Adult Psychiatric Mental Health Clinical Nurse Specialist Board Certified, and the Child Adolescent Psychiatric Mental Health Clinical Nurse Specialist Board Certified. While these examinations are no longer given, you will still find many nurses who practice in these roles. Their credentials will continue to be renewed if professional development and practice hours requirements are met. Future issues for psychiatric mental health nurses. Significant trends will affect the future of psychiatric nursing in the United States. These trends include educational challenges, an aging population, increasing cultural diversity, and expanding technology. Educational challenges. As with other specialty areas in a hospital setting, psychiatric nurses are caring for more acutely ill patients. In the 1980s, it was common for patients who were depressed and suicidal to have insurance coverage for about 2 weeks. Now patients are lucky to be covered for 3 days, if they are covered at all. This means that nurses need to be more skilled and prepared to discharge patients for whom the benefit of their care will not always be evident. Providing educational experiences for nursing students is challenging as a result of this level of acute care and also due to the declining inpatient populations. Clinical rotations in general medical centers are becoming more difficult to obtain. Faculty are fortunate to secure rotations in state psychiatric hospitals, Veterans Administration facilities, and community settings. Community psychiatric settings also provide students with valuable experience, but the logistics of placing and supervising students in multiple sites has required creativity on the part of nursing educators. Some schools have established integrated rotations that theoretically allow students to work outside the psychiatric setting with patients who have mental health issues. For example, caring for a person with major depressive disorder on an orthopedic floor. Some faculty are concerned that without serious commitment, this type of specialty integration may water down a previously rich experience. Nurse-led medical health homes and clinics are becoming increasingly common. Community nursing centers that can secure funding serve low-income and uninsured people. In this model, psychiatric mental health nurses work with primary care nurses to provide comprehensive care, usually funded by scarce grants from academic centers. These centers use a non-traditional approach of combining primary care and health promotion interventions. Advanced practice psychiatric nurses have also been extremely successful in setting up private practices where they provide both psychotherapy and medication management. An aging population. As the number of older adults grows, the prevalence of Alzheimer's disease and other dementias requiring skilled nursing care in inpatient settings is likely to increase. Healthier older adults will need more services at home, in retirement communities, or in assisted living facilities. For more information on the needs of older adults, refer to chapters 23, 28, and 31. Cultural diversity. Cultural diversity is steadily increasing in the United States. The United States Census Bureau notes that the United States will have a majority-minority population by 2044. Psychiatric mental health nurses will need to increase their cultural competence. Simply put, cultural competence means that nurses adjust their practices to meet their patients' cultural beliefs, practices, needs, and preferences. Science, technology, and electronic healthcare. Genetic mapping from the Human Genome Project has resulted in a steady stream of research discoveries concerning genetic markers implicated in a variety of psychiatric illnesses. This information could be helpful in identifying at-risk individuals and in targeting medications specific to certain genetic variants and profiles. However, the legal and ethical implications of responsibly using this technology are staggering. For example, would you want to know you are at risk for a psychiatric illness such as bipolar disorder? Who should have access to this information? Your primary care provider, insurer, future spouse, or a lawyer in a child custody battle? Who will regulate genetic testing centers to protect privacy and prevent 21st century problems such as identity theft and fraud? Despite these concerns, the next decade holds great promise in the diagnosis and treatment of psychiatric disorders, and nurses will be central as educators and caregivers. Scientific advances through research and technology are certain to shape psychiatric mental health nursing practice. Mri Research, in addition to comparing healthy people to people diagnosed with mental illness, is now focusing on the development of preclinical profiles of children and adolescents. The hope of this type of research is to identify people at risk for developing mental illness, which allows earlier interventions to try to decrease impairment. Electronic healthcare services provided from a distance are gaining wide acceptance. In the early days of the Internet, consumers were cautioned against the questionable wisdom of seeking advice through an unregulated medium. However, the Internet has transformed the way we approach healthcare needs and allow people to be their own advocates. Telepsychiatry through audio and visual media is an effective way to reach underserved populations and those who are homebound. This allows for assessment and diagnosis, medication management, and even group therapy. Psychiatric nurses may become more active in developing websites for mental health education, screening, or support, especially to reach geographically isolated areas. Many health agencies hire nurses to staff helplines or hotlines, and as provision of these cost-effective services increases, so too will the need for bilingual resources. advocacy, and legislative involvement. Through direct care and indirect action, nurses advocate for the psychiatric patient. As a patient advocate, the nurse reports incidents of abuse or neglect to the appropriate authorities for immediate action. The nurse also upholds patient confidentiality, which has become more of a challenge as the use of electronic medical records increases. Another form of nursing advocacy is supporting the patient's right to make decisions regarding treatment. On an indirect level, the nurse may choose to be active in consumer mental health groups such as NAMI and state and local mental health associations to support consumers of mental health care. The nurse can also be vigilant about reviewing local and national legislation affecting health care to identify potential detrimental effects of the mentally ill, on the mentally ill. Especially during times of fiscal crisis, lawmakers are inclined to decrease or eliminate funding for vulnerable populations who do not have a strong political voice. The APNA devotes significant energy to monitoring legislative, regulatory, and policy matters affecting psychiatric nursing and mental health. As the 24 hours a day, 7 days a week caregivers and members of the largest group of healthcare professionals, nurses have the potential to exert tremendous influence on legislation. However, when commissions and task forces are developed, nurses are not usually the first group to be considered to provide input and expertise for national, state, and local decision makers. In fact, nursing presence is often absent at the policy-making table. Consider the President's new Freedom Commission for Mental Health, which included psychiatrists, medical doctors, psychologists, PhDs, academics, and policymakers, but no nurses. It is difficult to understand how the largest contingent of mental health care providers in the United States could be excluded from a group that would determine the future of mental health care. It is in the best interest of consumers of mental health care that all members of the collaborative healthcare team, including nurses, be involved in decisions and legislation that will affect their care. Current political issues that need monitoring and support include mental health parity, discriminatory media portrayal, standardized language and practices, and advanced practice issues such as prescriptive authority over Schedule II drugs and government and insurance reimbursement for nursing care. And that's it for Chapter 1. Booyah!